So, welcome to everyone who's joining us online. So, Rob, what do you see?
So I see significant mucosal crusting, hemorrhagic crusting on the vermilion, as well as scattered across the face and the forehead.
Okay.
Appears to be sparing the conjunctiva.
I see where you're going with this. Patient is fairly dark-skinned, African American, and there are no crusts. The pathology is the depigment.
Oh. Okay. In that case, I mean, so.
But I can see how your eye, might do exactly the reverse as to which is the pathology.
So, I mean, extensive vitiligo.
Like extensive vitiligo, and does the patient look pale and hardy?
They're pretty sick.
Looks pretty sick, and it's all part of the same disorder.
Okay.
And with hearing loss and neurologic deficit, visual disturbance, anything that contains pigment. So, white Koinagi Harada. And what patient did we have in grand rounds who has essentially segmental blastoid variant of this possibly?
African Allison
Green syndrome, which is segmental retinal degeneration, which is essentially a segmental blastoid form of PKA, which is autoimmunity against melanocytes and wreaks havoc because of all the places melanocytes are required for functioning in the body. And this is another patient who is some treatment. So, it tends to be a segmental distribution. You can have extension onto the arms, sometimes like our patient had, or it can be more like, typically it's a V1, V2 kind of distribution together with visual disturbance and sometimes auditory, variable CNS depending where it hits. Okay, great.
So it's like a yellowing, maybe thickening of a nail coat. Tinea would be something that I would think of.
So tinea, there's certainly some pigment under, it's probably like a greenish pigment, it's probably just more pseudomonas. Pigment secondarily underneath. Do you see any cuticle? Is the cuticle pathologically missing? Missing. Second choice, shockingly enough. So, what would you call a syndrome typified by yellow nails?
Yellow nail syndrome?
Very good. And what are the components of yellow nail syndrome? Other than the obvious.
Yellow nail.
So yellow nail.
Pulmonary complications.
Pulmonary, so what's it usually associated with?
Not sure, to be honest.
So anyone want to
pulmonary fibrosis.
pulmonary fibrosis. And you're thinking with Bernhardt Bay, with the spontaneous
bronchiectasis.
Yeah, Justin is correct. Bronchiectasis is 95% of all patients. And if they don't have bronchiectasis, you got real trouble because they have pulmonary effusion, usually because of tumor and coastal lymphoma. So, you just hope they have bronchiectasis because if they don't, it's easy. There are sporadic reports of things like yellow nail syndrome associated with HPV. And when you look at the pictures in most of those reports, there are nicotine stains on the nails. And the pigment usually follows the proximal curvature, which is a big hint that it's an exogenous pigment. Endogenous pigments usually follow the outline of the matrix, which is the lumina, whereas exogenous pigments usually follow the morphos or reverse curvature. There's no credible evidence that any of those reports are Yellow nail syndrome, there should be loss of cuticle, no growth of the nails. So you ask her, when was the last time you trimmed your nails? 2 years ago. Because they just don't grow, they just sit there. And increased curvature in all directions like a tortoise shell. That's the classic.
Why do they
I think it's just building a carotenoid because of the increased thickness of the nail plate. So all nail plates probably have yellow hue because of the carotenoids in the keratin layer. It's just the thicker it gets, the more yellow you see. Just like hyperkeratosis on the heel looks yellow just because of that increased thickness of carotenoid and yellow. Anything that starts with some has yellow. Okay.
So looks like pustules in this face,
Pustule or
juicy
vesicle with a necrotic groove that therefore gets a whitish, somewhat opaque appearance. Second one likely. So, and pink is the periphery of them are still translucent. It's more towards the center that they're white, whereas a pustule tends to be white over the full dome. So, that's a hint. We see lots of things that have superficial necrosis and are the white hue. And if you poke them, what you get out is something clear rather than pus. I'd say this probably falls into that. What else could you say? So for us, everything is color, morphology, distribution. We do pretty well with color. How about morphology and distribution?
They appear fruit.
Fruit. Do we have a word that we use for that? Herpetiform. Very good. Why do you use such a word? Yeah, because it's a tendency that things like HSV have, but also things that are called herpetiform, like pemphigoid herpetiformis, titus herpetiformis. We have lots of herpetiform things that are because of their tendency to have aggregated groupings of vesicles. And then, how about the morphology? Are they all smooth, round domes, or is there some central disruption to that dome-like structure? And how might one describe that? It's umbilicated, like in this little belly button. So, umbilicated vesicles on an erythematous base and a herpetiform distribution. What are you thinking? So HSV, how often is HSV hemorrhagic? So what closely related is more likely to be hemorrhagic, highly inflammatory? Like a zoster. Exactly. So I'd say this is more likely zoster. Zoster has histologically underlying leukocytoclastic vasculitis that's usually pretty prominent, whereas simplex does not. Of the two, zoster is painful, zoster scars, all because of that underlying vasculitis, which is also what makes it more likely to be hemorrhagic, deeper red, more necrotic. And it's just a little closer look at vessels with a necrotic surface versus pustules. One of the clues also to a viral blister, see how it keeps your skin cross-sections? Most, like immunobullous disease doesn't do that. But viral blisters, because they have a variety of usually a mix of ballooning and reticular degeneration. The more reticular they are, the more you preserve the cross hatches. This was the structure of this image. Okay, so we do that one. Close that. Okay.
Any here?
Okay, Caleb, what do you see? When I heard James, they had the baby. What do they have?
A boy.
Boy. We knew that, right?
Mm-hmm.
Okay. So what's his name?
Anderson.
Anderson.
Mm-hmm.
You got Ezra and Anderson.
Yes.
Okay, go ahead.
There's some just really on the thighs and feet, red papules, and I can tell some may have some crust or some scale.
Yeah, so I definitely make out some epidermal change. Definitely changes to the differential. All similar in morphology or appearing to be various stages of evolution?
There appear to be in various stages of evolution. The one higher up in the bottom is sort of a little wheel
And this is one that was not mine, so we always give credit. Cutis has given us permission to use some of their photophrases, and Rutland Kansas for Madison has some Cutis. So this comes from one of those two sources. Usually will pop up just a little citation. It does have a small okay, and then you get half. And since half is true, where would you say the pathology is localized? Yes, if you don't have that.
No, it's like the DE junction.
Looks like DE junction. What do you see going on here?
There's a lot of lymphocytes.
A lot of lymphs. Would you say at a glance that there are holes out of proportion to lymphs, or more like a lymph in every hole?
Kind of looks like a lymph in every hole.
Kind of looks like a lymph in every hole. So what would be your differential for interface dermatitis with a lymph in every hole?
MF, PSC,
Yeah. So I mean, MF are your top three, and then and it even looks to me like we have a little epidermal linking like fibrosis there, so which would put MF higher, even though it was smaller macules. You know, MF is usually bathing suit area greater than 5 centimeters of intraocular dermatitis, but you can have cupcake forms of MF and filter and other forms. Pityriasis like moides, as you said, be high on your list. Early evolving stage would be okay, that's likely. Always remember syphilis grains in that list too. You never want to miss that one. It's pretty good for the immune manifestations. And it's definitely lymph in every hole. There's definitely a little papillodermal fibrosis, which weighs a little against Cleva since each lesion tends to be a little protein Cleva. Okay. 3, 4, and 8 there. So, David, that's budding dermatopathologist. What do you think?
And if you expect the C4-8 ratio to be high, so it looks like it is high here.
And it's usually 5 to 1, 10 to 1, pretty extreme. And pityriasis like moides, how does that tend to stand?
The more CD8?
Yeah, it's much more CD8, cytotoxic phenotype. And so this is kind of the anti-Cleva in the way it's standing. Any forms of MF that tend to be CD8 predominant?
Yes. Hypopigmented?
Yeah. So hypopigmented MF, which is usually black kids. So, the vast majority of hypopigmented MF are black children who have hypopigmented lesions, usually a little larger than pityriasis lichenoides. But it becomes very important differential because that is usually the clinical differential for them. You see a black child with definite hypopigmentation, it's either hypopigmented MF or it's pityriasis lichenoides, and both tend to be CDD positive. So, that can be a little dicey working your way through from the reason. So, in this case, it was called PLC dihistory. Apparently these were evanescent evolving lesions, lesions in every hole. With a little papillary dermal fibrosis, I would watch closely. Based on the clinical, it was presented as unlikely to evolve as MF. The more papillary dermal fibrosis you have, the more you have to worry about. How helpful would clonality studies be in this case? No. Because Cleveland's cornal as often as early methods. So, that would, if anything, maybe lead you in the wrong direction. So, this is someone you treat how? How are you most likely to treat them? Methotrexate if it's bad, or exactly. So usually narrowband is where I would start. If they're unresponsive or if it's very disfiguring, methotrexate shuts it down beautifully. So that's exactly what I'm doing. And both of those are perfectly acceptable treatments for evolving MF as well. So no harm, no foul. You treat them and you follow.
What about like erythromycin?
Yeah.
Or for kids?
That and tetracyclines, the literature is chock full of it. Never in my hands a heart. Certainly buys you time. It's a lot like all the reports of erythromycin and pityriasis rosea. When you really read when they respond, it's kind of would have gone away. So I'm not sure. There's certainly believers. I'm not sure, honestly. Whereas, light, absolutely, methotrexate, absolutely, because you get dramatic effects.
So it looks like you have a maceration in the third.
So intertriginous site, and it's macerated to the point where it's white. And when it's macerated to the point it's white, what do you think the condition of the epithelium is?
It's probably
Yeah, compromised in some ways. So it's macerated, sucking up more water. And then is it macerated but holding together, or macerated becoming apart as red rents or tears in what looks like macerated white tissue paper? The second one. And what does that describe?
I'm thinking
Yeah, exactly. It's the classic description.
So it looks like we're on the trunk, the abdomen, and there's kind of a shelf or like normal skin up top, and then below there's like a milky marking, black. I think I might have had so it's kind of like peau d'orange look a little bit.
So peau d'orange.
Peau d'orange.
It's just with French just means orange skin.
So it could just be kind of like stasis in the panis.
Yeah, so what you're saying when you say stasis is what's called lymphedema of the panis. So localized lymphedema of the panis or lymphedema of the panis is very common. It usually is post-streptococcal. So if you were thinking this could be something like erysipelas, you're absolutely right. And the question is just how tender is it today? If it's really tender today, it's erysipelas today. If it's this like edema at Hannah's, it was erysipelas 6 months ago, or that scarred your lymphatics and gave you the chronic lymphedema. And the most important thing about it is that your lymphatics are dilated and you get hyperchromasia and sometimes marked lymphopenia in the forehead. So you biopsy and someone wants to call it an angiosarc. And sometimes your fibroblasts are large and hyperchromatic, and they want to call it a soft tissue sarcoma. And step back a little. Okay? If there's ever a question like that, this, like steward trees, you can do your NIC amplification by fish. If they're NIC amplified, they're going to behave like sarcoma, like angiosarcoma. And if they're not NIC amplified, it's just in the spectrum of lymphedema to atypical vascular lesion AVI. That's a year, so this is a neck. And judging by the little fine hair, it's probably a tail.
Okay. So I guess she kind of have like a shiny plaque in the center. Is that right?
Yeah, so I think everything's normal except for this papule with whatever's sticking out of it.
So, are we thinking like a branchial plexus?
So it's a great location for branchial cleft, and that's I think what this one actually turned out to be. The other thing you might think of though, if it's a papule, it could be congenital, it could more likely be acquired, often in an older individual. But a papule, if that was a little tuft of hairs coming out of the papule, it might be congenital. Tuft of hairs that came from all the babies entering mama.
Oh, trichofoliculum.
Like a trichofoliculum. But that's rarely a congenital. That's usually an older person that's required. So this in a kid, you are absolutely right thinking more congenital. So branchial cleft and bronchogenic, they overlap in distribution, they overlap in histology. The separation is probably more artificial than real, because you see hybrid forms. But if it's got lymphoid follicles in the wall, call it a branchial cleft. And if it looks more like bronchial, then you call it a bronchogenic. But it's all variants of the same. And that I will help you with an ankle. Okay. And judging by the cholangiocases and lymphedema hemosiderosis, how old do you think this ankle might be?
Elderly.
Elderly or older is politically correct. So
I would say like a pink to red, dome-shaped papule, kind of shiny on top.
So surface very shiny, and a little hint of a collarette of a silver scale.
Under, I think, like that.
And a very characteristic appearance that you can see here grossly, and really comes out in dermoscopy. Too, when you have this reticulated white, which is the epithelium, as well as the red, which are the dilated papillary vessels. So you almost see your dermoscopic appearance grossly.
Okay, some kind of nevus.
You know when they come Yeah, I think these are clear-sighted. That's exactly what it is. And that's pretty much what the dermoscopy looks like, and you can see it pretty well closely here. And interestingly, when you do confocal, you get the same pattern in confocal. Kind of that Swiss cheese in the epithelium with the vessels. I only know that because the Robert Wood it's a really slick confocal. And and then that little, it's usually a more complete collar at the silver scale again. So when you see it, you're often thinking psoriasis, but it's odd that the scale is not on the surface, it's just around the edge. And then it certainly will be psoriasiform. Does it have neutrophils like psoriasis?
In the crust.
In the crust and actually throughout the epithelium too. Like it has that clear cut off where it becomes like
So we have a lateral gravel. What looks like maybe a kid. It's like a darnoid cyst, maybe.
yeah, exactly. So classic distribution. So color morphology distribution is always what we go by. So color here, it's just kind of skin color because it's heat. Morphology, it's a deep knot color. And it's really distribution because it's the patient's age and distribution that's something general. So the question is, can you excise these? Do you send them to neurosurgery? Do you get CT scans with drone windows? Do you get MRI? What do you do?
It depends on the location. I think that one is okay with me not to get in, but it's like a long period of time, so you have to get additional imaging.
And you're absolutely right. So, the dogma has been any congenital midline lesion or fusion plane lesion must be imaged before surgery. But there's good data now that if it's a lateral eyebrow dermal, the chance of a connection is minimal. A lot of people will simply do surgery on them with no imaging. Whereas a medial eyebrow dermal is more likely to have a connection. Of course, if you're doing surgery and every time you pull on the says the eyes bug out, I would stop. But we have a lot of support in the literature now that a lateral eyebrow dermal imaging is probably not cost effective, whereas most other more midline congenital lesions still require. So you're correct, it's upsetting.
See, almost black appearing macules.
So tans of black appearing macules, and what else?
I have some
And comedones, correct. So idea of the diagnosis is that so nevus comedonicus, does that tend to affect the whole axillary vault, or is that more likely a skinny linear blastoid segment because it's a lethal gene that kills the tissue, so it's only about a quarter of the width of what a blastoid segment ought to be? Probably the second one. And actually, when you go to excise them, you really have to cut beyond the borders of the nevus comedonicus, because within that, the collagen is bad. You can't even suture together. The suture just pulls through, because it really is a lethal gene that kills the tissue, which is why it's got such a skinny segment. And why, if you have systematized nevus comedonicus, or even if you were just hit with one, and unfortunately if they were your face or calvarium distribution, you can have seizures, you can have all sorts of problems because it's lethal to whatever was in that segment, that fetal segment of tissue. This is more over the entire axillary vault. So anybody?
Foxfordays.
So foxfordays would be skin-colored little papules that are the epithelial area.
Dowling-Dagos.
Dowling-Dagos, right. So in Dowling-Dagos, reticulated pigmented anomaly of the flexures, but if I were naming it, it would be reticulated, but it's usually more macular. Pigmented, and by the way, there are lots of comedones, anomaly of the flexures. Because that's usually a more apt description for what you see. And histologically, what are you going to see from this?
It looks like sides.
Yeah, it looks like reticulated said, but it's hanging off the hair follicles, accentuating off the hair follicles. Some on the surface, but really prominent on the hair follicles where you have those terminal openings. And in Fox Fordyce, so Justin, this goes to you as the fellow. In Fox Fordyce, what is the most common histologic finding? One might think you would see the apicriminal area, right? Because that's what the condition's called, but that's not what you see. A couple of good papers now, and what you see is a pair-off follicular xanthoma. So you got xanthoma cells sitting out in the dermis. So that, in an axillary breast distribution, is Fox Fordyce. And, because it's, I guess it's from rupture of the prior rupture of the apicrine duct that you get the xanthoma, but it's not what you think intuitively, and yet that's what you see most of the time. So important to know for practice, and also potentially very testable, because it's, unless you know it, you're not going to guess it.
Is it free or is it going back?
It's in max spots, so it's not like an eruptive xanthoma where you have extracellular working. It's just you've got xanthoma cells sitting next to a follicle. Not what you would expect to see in an active miliaria, but it's probably wider, more persistent papular, because it, that's the residuum of what happened.
Looks like a fresh haired sort of cystic structure. I'm not exactly sure where you are.
Yeah, so that can be at least anywhere in glabrous skin. Right?
Yeah.
In glabrous skin, what is that for name?
Glabrous skin?
Glabrous skin.
I don't know.
It's usually normal hair-bearing skin, so anything that's not volar. So volar skin would be palms and soles, right?
Mm-hmm.
So it's not volar skin, it's not hair-bearing scalp. It's the sort of like everything else is glabrous skin. So glabrous skin, you got a little like cleave over it. It's got a little bluish gray appearance maybe to it. And then the question would be, is that related to it or is that not related to it? If that's related, then what is your problem?
I'm just opening this list.
Yeah, it's just an epiderm that says if that's related. And if that's, something, if that's a red herring and not related, then things that are bluish like that, I don't think pyometricomas, various things like that can be bluish. Whereas tumors like Merkel are more plummy in color. And this one just wasn't like this. A little pumpkin or something.
Root, brown, purple brown, productive papules.
So do you think histologically they would likely be seated in dermis? Or do you think they're more epidermal? What do you think?
It could be kind of intradermal, kind of pushing up, like it maybe get
Could be
intradermal.
intradermal, pushing up. To me it looks kind of stuck on, right?
Yeah. So could be epidermal nevus.
Absolutely. It's got a little linearity to it, and epidermal nevi should always roughly follow where the Blaschko segments would run. And that's probably what it is. It's just a epidermal nevus, all of the epidermal nevus syndromes, they can have underlying abnormalities, and if they are systematized, or again run over the face or scalp, you need an evaluation because there can be seizure disorder, there can be various issues.
So, I have linear plaques.
And so, linear Blaschko is one of our themes here.
Right. So you would think of like Ilven, Ichenstritis.
That's beautiful. So if congenital, probably open. If acquired, you might think of lichen striatus, but what color is lichen striatus in darker skin?
This would be more. I mean, I think of it being lichenoid, so purplish and
Hyper
colored.
or hypo?
Hyper, or so hypo.
Hypo.
Okay.
Lichen striatus is usually hypo.
Oh.
So when it's hyper like this, dramatically hyper, and you can even see the white reticulated pattern of Wickham striae here, which is the hypergranulosis. So dramatically hyper Wickham stria, that tells you it's lichen. And so when it's lichen striatus, despite the name, is not lichenoid histologically. It's more like lupus histologically. There's vacuolar in the face, there's lumps in the eccrine coil, patchy, except for the mucin, it really does look like lupus histologically. Whereas this is more likely lichenoid, and that is a lichenoid blastitis, which is essentially segmental lichen planus.
So it looks like a round cystic area.
And where is it located distribution-wise?
Medial on the other side of the scrotum.
And what is this structure called?
Median raphe.
Median raphe. So you were suggesting this is a median raphe cyst, and I would agree it would be unlikely to be anything else, considering that it is a cyst in the median raphe. And what do they look like histologically?
Kind of like isn't it like or no, it's you have debris-filled like
debris-filled cyst. So you're a midline genital cyst that's filled with crud, duct, debris of some sort, and the lining is variable. It can look apocrine with snouting. It can be ciliated. So the lining is very highly variable, but a crud-filled cyst on the midline genital region, in general region, is usual.
So we have, I don't know if it's to your scalp, it looks like total skin color, cyst,
So is it more multiple and inherited? It could be cylindroma. Even solitary, it could be cylindroma. When inherited together with trichoepis, it's what syndrome? Brooks-Spiegler or Rasmussen. They actually describe them around the same time, so both names are used for it. And it's the same syndrome. So, and if it really is a cyst, kind of firm and rubbery.
like a power.
Yeah, I mean, it could be EIC. You see those on the scalp, but more likely a pilar cyst, especially familial and multiple, more likely pilar.
I took one out yesterday that looked exactly like that, and then it was a lipoma.
And it was a lipoma.
Yeah, we thought it was pilot.
You see that, you'll see various things that mimic it. Common things being common, pilar, and usually you can make a stab wound or a punch wound and just give birth to it through that small, it crowns and it pops, and the patients get a big laugh and you say congratulations if you go. Okay. Yeah, so this is a little more tumor-ish, right? So it's but this particular one is a proliferating. And so proliferating pilar cysts, where you still can identify the cyst wall, are benign. And proliferating pilar tumors if they have significant atypian mitosis, they're capable of metastasis, and they're probably best regarded as low-grade squamous carcinomas. So you've got to be a little careful if you can't make out the remnants of the cyst, how you manage it and what you call it. And that is a neglected. So this is from the VA.
Don't tell me the backstory.
And
Yeah.
this is a neglected. It was completely benign. This was a benign proliferating pilar cyst that grew. They actually can grow quite rapidly. He was Dr. Fovic, and would be coming in. And the story apparently was his wife made him come in because her dog would no longer pay any attention to her because it followed him around, waiting for the next chunk to fall off her
Kind of looks like a pizza.
Definitely a deep dish.
But because it had already worked like a tissue expander, it was apparently just dissected out, and he had his own flap ready for closure, and it was benign, and did well with surgery, is what I was told. And the slide is in the public domain.
It's like one of these yours or couples, thinking like a steatocystoma.
Yeah, so steatocystoma, and they, as they progress, they often resemble nodular cystic acne with scarring. And if you poke them, they drain oil with vellus hairs. So steatocystoma, absolutely. If they're more keratin-filled, maybe eruptive vellus hair cysts, so this would be a little on the large end for that. And they were steatocystoma.
Left ear, posterior helix, lots of clippoderma, some damage, and then this sclerotic plaque on the upper helix. You can think about like a DFSP or morpheophone basal maybe.
Yeah, are DFSP, are they usually donut-shaped depressed in the middle, or are they usually multinodular?
Multinodular.
Usually multinodular. Whereas this is more, if anything, donut-shaped depressed centrally with a rim ranging outward.
Desmoplastic trichothelioma.
So what's the epidemiology of the demographics? I use the wrong term. Demographics of desmoplastic trichothelioma. What is your patient age?
Younger female.
Younger female on the cheek. Okay, whereas this looks like an older, judging by the haircut, maybe male, posterior ears, so less likely to be DTB. So obviously it's going to be that one is just basic. So this is a rare.
Okay. So we kind of have a well demarcated erythematous plaque with kind of some fine scale.
And when the scale
Almost crusty.
is silver or yellow.
It's yellowy.
Scale is usually silver.
Or scale is usually silver. That looks yellowy.
And this looks
Right.
yellow. Right. That's what I thought you were saying. And so the yellowy suggests maybe more crust, suggests presence of serum. This the scale. Judging by the presence of the cherry angiomas, how old do you think the patient is?
Probably middle age or
Yeah, probably older. Older rather than younger. And is it a sharply circumscribed lesion, or does it appear to extend beyond the bulk of the
well, I guess right, it's not sharply. It's quite extending. Like especially in the top right. But when I look at
what's
the
your differential? Obviously you're going to buy
I mean, so like extraordinary Paget's or
So,
just
Paget's
standard
would be right up
Paget's.
there. Paget's, Bowen's, Could the whole thing just be a crusted, irritated seb? I suppose. But this is when you really would want to biopsy because you're changing morphology in this one too. Seb next case.
So you have like a tan, multi-centric plaque. It's got a few concerning areas in it. I'd say like the area up top in the center has a little bit of crust.
Yeah, so
Different
areas of
colors.
crust, areas of erythema, not so much skip areas as older scar-like looking areas. And the whole thing is fairly sharply circumscribed, but with a markedly irregular border. So, differential.
So seb would be in the differential.
So seb that's had a really bad one.
Melanoma.
Melanoma
Within
tends out
the
to be
primary lesion.
keratotic on the surface, but I would not rule it out entirely. So the secondary change over a melanoma. Anyone else? Yeah, in bones, this is actually, the pigment, the erythema, the keratotic, the irregular border, kind of seb from hell look is one very characteristic appearance that bones can have. That's where I would go. Okay, we are out of time, so we are, if several people will make note of it in their cell phones, we are on slide 31, set 4. And now we'll go with it. So, goodbye to everyone who joined us on that.